6 per page slides, and I'll just release I was going to do it now. I will just make sure that you have the PDFs in color of all of them as well. Okay, so when we talk, I limited our discussion of gastrointestinal disorders basically to ulcers and GERD. Okay, gastroesophageal reflux disease. Have any of you had patients with these issues or on medications for them? No? Anyone seen any signs of GERD on the teeth? Now that you know, when you see what they look like, you will, they kind of look like they're melting sometimes. You will probably recognize them in the future. One of the things I think your book points out that you can look up more information on that's really fascinating is that connection between our stomachs and our emotions. And I don't think any of us will doubt that, right? You know, the old gut brain, they call it. They think that the gut is kind of our primal brain, if you will, and that while the central nervous system can affect the gut, if the connection were severed, the gut would still work on its own. It's kind of strange. And you always hear about people having the whole headache, tummy ache thing, you know, when they're stressed out or feeling ill. And there's definitely a reason for that. And one of the reasons for it is because of that connection with the vagus nerve, okay? The vagus nerve is the 10th cranial nerve, and it's highly subjected to emotional response, and it has that response into our gut, as well as a lot of other systems in the body. But it's definitely affected by the autonomic nervous system, both the parasympathetic and the sympathetic nervous system. And they sometimes call the gut your ENS, or your enteric nervous system, or your gut brain. And if you look that up, if you get interested in that in terms of like nutrition and how our body behaves, I think you'll find it absolutely fascinating. So with gastrointestinal disease, you know, we talk about a nervous tummy ache, and it sounds like kind of a funny thing, butterflies in our stomach, or, you know, getting nauseous, as somebody was just saying they needed an antiemetic after the exam, you know, but it definitely is, there's definitely a physiological connection for that. When it comes to GERD, or gastroesophageal reflux disease, that's what we commonly call heartburn, and it has to do with the location of that feeling, okay? At the cardiac sphincter muscle. And the cardiac sphincter muscle is not in the myocardium, it's not in the heart, it's actually in the beginning of our stomach. It is the most prevalent gastrointestinal disease in the US population. And what happens is the acidic contents of the stomach back up through that sphincter muscle, and they basically kind of burn it and wear it down, if you will, after a while. But that's what we feel, and we've all had it to one extent or another. It is associated with eating large meals, eating late at night, eating acidic foods, but it's not just limited to those things. Barrett's esophagus is the syndrome that can develop when people have that type of situation currently, and many people are on these medications which will help to control stomach acid because of that. Laying in a supine position, and we all know how uncomfortable it is to eat a large meal and then lay down after it. You know, so like after that big turkey dinner at Thanksgiving, you know, even though you're sleepy from the turkey, you shouldn't be laying down right afterwards. You should digest a little bit. The irritation and the inflammation, of course, cause pain, and people have actually mistaken heartburn for a heart attack. And unfortunately, indigestion is one of the things that happens when someone's having a heart attack. So that confusion is only exacerbated by that. So we really have to, you know, be aware that if somebody has heart disease and they keep saying they have this heartburn feeling, it may actually be the signs of a heart attack. So they can be easily confused both ways. Orally, I wanted to show you some. Yeah, go ahead.
The lesions in Barrett's esophagus are precancerous, right?
They can be because of the tissue changes. It's associated with precancerous lesions, but it doesn't necessarily mean when you have it, it would lead to it. But they can be, yeah, they can be. And that's true with, I think, anything that causes, you know, tissue damage, and changes can lead to that for sure. Because then sometimes you'll get, the body will throw off a proliferation of tissue in order to heal it. And we know that proliferating tissue that doesn't get to make itself as differentiated as it should be, non-differentiated cells can cause cancer. So yeah, for any of those reasons. So some of the oral manifestations that you may see is that the early lesions start to almost like smooth out the tooth morphology because of the acidic contents that are constantly backing up, if you will. Non-eroded teeth, okay, will look like they have clear pits and fissures. Eroded teeth will look as if they're smoothing out, and sometimes you'll actually see the like amalgam restorations, which tend to last forever, okay, even though they break down somewhat, they tend to be there forever. You'll sometimes see that the restoration is raised above the surface of the tooth because the calcified surface of the tooth is kind of melted around it lower than the surface of the restoration. So that's one of the things that also that you should look for. But early lesions would look like the picture on the left, kind of like a little bit of a melted tooth. And then later lesions get to be very, very bad. And someone who has this constant reflux may actually have tissue irritation within their mouth. And this is a real problem. In situations of anorexia nervosa, when people vomit constantly, you will actually see the surfaces, the lingual surfaces of the teeth worn down. And if you see this, especially in young women, seem to be the most common, but it's also has some prevalence in men. If you see especially a young person like in their 20s that has this type of erosion on the lingual surfaces of their teeth, you know, you may start to ask a couple of questions. You're never going to say, oh yes, I throw up because I'm trying to lose weight, but you know, you may want to look at their overall persona and see what they're going through to kind of, you know, alert you to that fact. And if it's a regular patient, you can definitely follow them and you'll be dealing with some of the results of it. So you see again that classic lingual erosion that's going on there. And then one of the things, you can't see it really well up here, but you will see it on your computer, is erosion of the little cusps of the teeth. And you see almost like a little pit in the cusp of the teeth. And that can come from a combination of this, the GERD as well as grinding the teeth. But it's kind of a classic syndrome. And one of my students had noticed that this has happened several times, and she said it's really weird. There's like these little, and it wasn't decay. There's these little pits that are in the cusps of the teeth. And I right away looked to see if the patient had GERD, and they didn't notice. And I said to him, do you have GERD, like acid reflux? And he said, oh yeah. But he just thinks, people just think I just have an upset stomach a lot, you know, or I eat big meals, or I eat fried food, or whatever it might be. And so it is definitely something you will start to notice now that you've seen what it's like. The treatment, of course, first we always like to go with the lifestyle changes and the dietary changes. But you know, if, failing that, we have to deal with the circumstances and deal with it with drugs. And sometimes what they do is give something that gives more muscle tone to the cardiac sphincter to make it stronger. Okay, when we talk about tone, you talk about the muscle contracting, okay, and being just like when you talk about loss of tone or that it becomes tonic, the tonic seizures, it's actually contraction of the muscles, not relaxation. So you try to actually get that muscle to contract when it's not doing that properly. And also decreasing acid in the stomach through either medications or dietary changes. But if we do have to use drugs, the major classifications are going to be the histamine or the H2 block, which is H1 and H2, right? Receptors. So blocking the H2 receptors seems to help. And there are proton pump inhibitors. We're going to talk about all of these separately, which can help to reduce or eliminate some of the acid in the stomach. Then there are those stimulants that I talked about that can that increase the tone of that cardiac sphincter and make it harder for the contents to back up. And then antacids are used to reduce the stomach acid for acute symptoms. And very often we use a combination of 2 or 3 of these kinds of medications. Ulcers are another thing, peptic or stomach ulcers. And they occur in the stomach and small intestine. And we used to think that it was specifically only dietary and acidic problems that cause these problems, these ulcers to develop. We now know that most of them are caused by actually a bacterial infection called H. pylori, and that's what the bacterium looks like. Ew, right? But we have these normally, just like any of the things that give us problems, we have these normally in our gut, okay? They're there for a reason. But if we get a proliferation of this, we actually need to treat the ulcers with an antibiotic. And I don't know if you've known anyone who's been on H. pylori treatment, but the antibiotics are pretty strong, and they can feel pretty sick for a while once they're undergoing the treatment for it. So they might give an antibiotic and an H2 blocker or a proton pump inhibitor at the same time, and they help to, quote, cure the problem. It can come back, but generally you hit it hard and you hit it as early as you can, and you're going to get rid of the problem. Some ulcers are due to chronic use of NSAIDs. Do you remember that NSAIDs, remember that they inhibit prostaglandins, and that prostaglandins actually have a cytoprotective or a cell-protecting effect by producing mucus in our gut. So if you take too many NSAIDs and you inhibit the prostaglandins, you inhibit our ability to produce that protective mucus in our stomach, and a lack of the mucus causes the acid to cause more ulcers. So elderly people that have taken NSAIDs maybe chronically for things like arthritis or other pain, because they don't want to take opioids or that kind of thing, wind up also with these NSAID-induced ulcers. Okay, and the most common medication used for that is misoprostol or Cytotec. That is commonly used for NSAID-induced ulcers. So we're going to discuss the histamine blocking agents, the PPIs, and then that mixed therapy that's used to treat the ulcers, as well as antacids. So the histamine blocking agents are treatment for both ulcers and GERD. You're going to notice with these that there's a lot of, there are different medications that are used for both indications, if you will. So they inhibit the gastric acid that's going to be secreted by competitive inhibition of histamine, okay, at the H2 receptors, the histamine 2 receptors in the stomach. So they give it at meals or at bedtime, or for people that get these recurrently, they give it maintenance once or twice a day. We do know that smoking increases acid in the stomach, and it also decreases the drug's effectiveness. So smoking cessation would definitely be indicated for people. Cimetidine is the prototype that was used previously. It's used less often because it had more negative side effects. And then I'm sure you've heard of Pepcid or Zantac, famotidine or ranitidine. These are the drugs to know, and they have fewer side effects than the original Tagamet drug. Some of the adverse effects could be that antacids used to treat the excess acid in the stomach. Why do we have acid in our stomach? What does it do for us? Breaks down food, right? Okay, it helps us to digest. So if you decrease that too much, we're going to have difficulty sometimes absorbing food, and it also may block the absorption of other medications. So we have to be really, really careful. So you shouldn't take even the H2 blockers or the PPIs within an hour of taking the antacids. So if you're taking both of them, they have to be spread out. They can have central nervous system effects. They can slur your speech. You can have delusions, confusion, headache. Again, these are with chronic users. And they can have anti-androgenic effects on males and sexual dysfunction as well. So sometimes people complying with their medication can be thrown off if they find that it has that effect. Liver effects, hematologic effects, constipation. Think about that you're not having proper digestion. Xerostomia is big, as it is with a lot of medications. And then the interactions with the drugs in terms of absorption, and we talked about this when we talked about antifungals, benzodiazepines, and alcohol can also interact with the drugs. So be aware of that when your patients are taking. These are really, really common drugs. The proton pump inhibitors inhibit the gastric secretion and help to heal the gastric and duodenal ulcers. It heals ulcers more quickly than the H2 blockers, and it's better tolerated, so it doesn't have all the negative side effects. Dry mouth is still there, unfortunately, and muscular atrophy of the tongue, kind of an interesting thing. So when you hear of patients having seen these weird kind of symptoms, you may kind of look at how long they've been taking certain medications and see that if they're related to them. Long-term taking them, risk of osteoporotic fractures. This is just something we know from post-market research on the drugs. And these are going to look really common to you: omeprazole and esomeprazole. So Prilosec, Nexium, really, really common drugs. Those are the ones that I want you to know. Stop me if I'm going too fast, but this stuff's pretty straightforward. So that mixed anti-infective treatment that I talked about for ulcer treatment is a combination of the antibiotic agents that are going to affect H. pylori, the acid reducer, either the H2 blocker or the proton pump inhibitor. We know the proton pump inhibitors have less adverse effects, so those are more common. And then an antacid, such as something like Pepto-Bismol. They may be put on an over-the-counter medication. A really common combination now would be something like the esomeprazole and clarithromycin. Just those two drugs alone may be used, but they're usually in high doses over a period of time to help to heal the ulcers or the H. pylori. Acute gastritis, of course, we use antacids for those. We've all probably used them at one point. They neutralize the hydrochloric acid, and they raise the pH, right? Because we know raising the pH makes it more alkaline and less acidic in the stomach. And really common ones, again, most of these are over the counter, something like sodium bicarb, baking soda, which actually can be mixed with water and you can drink it. Milk of magnesia, magnesium hydroxide, and calcium carbonate, and that would be probably the most commonly used, something like Tums or Maalox. And again, probably all of us have used these at some point in our life when we have that upset stomach going on, when we have an exam or something like that. And as I said, with the NSAID-induced ulcers, the misoprostol, you should know that is the drug of choice. It's actually synthetic prostaglandin. Remember, we've reduced the prostaglandins in the stomach, and so it actually increases the production of the cytoprotective mucus in the stomach, and so it kind of fights the effects of the NSAIDs, which tend to reduce it. So what you should know about this drug, importantly, is that it's a pregnancy category X, because it can induce labor. Prostaglandins are associated with contraction of the uterus, so that would be something that you would want to avoid during pregnancy. And that's actually it for that chapter, so pretty easy stuff, right? Compared to some of the other ones, like compared to like